Good morning. In this video, we're going to talk about biliary duct diseases. First, we're going to talk about obstructive jaundice because most biliary duct diseases would present as obstructive jaundice. So, jaundice or icterus is a yellowish discoloration of tissue resulting from the deposition of bilirubin. Tissue deposition of bilirubin occurs only in the presence of serum hyperbilirubinemia and is a sign of either liver disease or less often a hemolytic disorder. What are the causes of obstructive jaundice? Obstructive jaundice could either be intrahepatic or extrahepatic. In this topic, we're going to concentrate on the extrahepatic. In the extrahepatic, it could either be intraductal or extraductal. Now we go to the diseases that causes obstructive jaundice. First of all, we have choledocholithiasis or the common bile duct stones. This is 6 to 12% of patients with stones in the gallbladder would present with choledocholithiasis, and 20 to 25% of patients more than 60 years of age with symptomatic gallstones have also stones in the common bile duct as well as in the gallbladder. Choledocholithiasis may be silent and often discovered incidentally. It may cause obstruction or it may manifest with cholangitis or gallstone pancreatitis. Choledocholithiasis may be diagnosed by ultrasonography. Ultrasonography is useful in documenting stones in the gallbladder as well as determining the size of the common bile duct. Another way is by magnetic resonance cholangiography. This will give you an excellent anatomic detail of the biliary tree. This has 95 sensitivity and 89% specificity. However, patient uh, who undergoes MRC has 5% morbidity. The patient could develop cholangitis, also pancreatitis. Another way is by endoscopic cholangiography or ERCP. This is the gold standard in diagnosis of choledocholithiasis. It has a distinct advantage of providing a therapeutic option at the time of diagnosis. So it's diagnostic and at the same time therapeutic. However, it also has a 5% morbidity. Same with MRC. Patient could develop also cholangitis and pancreatitis. Another way is by endoscopic ultrasound. This is as good as ERCP in detecting CVD stones. It has 91% sensitivity and 100% specificity, and it also lacks in therapeutic, but it lacks therapeutic intervention as compared with ERCP. Another one is percutaneous transhepatic cholangiography. However, this is rarely needed in patients with secondary CVD stones. This is frequently performed for both diagnostic and therapeutic reasons in patients with primary bile duct stones. For the treatment, patients with symptomatic gallstones, suspected CVD stones, will have a preoperative endoscopic cholangiography or ERCP, and then sphincterotomy and ductal clearance of stones. So the stones will be extracted through ERCP, and then after that, patient should undergo laparoscopic cholecystectomy. Another form of treatment for patients with symptomatic gallstones and suspected CVD stones, the patients could undergo intraoperative cholangiogram during surgery, and then if there's stone detected in the CVD, then we have laparoscopic common bile duct exploration, or could also be open common bile duct exploration and T-tube insertion. However, if the stones are impacted in the ampulla, then choledochoduodenostomy is done, or Roux-en-Y choledochojejunectomy is done. For retained stones or recurrent stones after cholecystectomy, uh, by the way, retained stones are stones that are deliberately left in place at the time of surgery or diagnosed shortly after cholecystectomy. So what is done in this patient is endoscopic retrieval or via tissue tract once it has matured 2 to 4 weeks. And for recurrent stones, these are stones that are diagnosed months or years later after cholecystectomy. Uh, the management of this is endoscopic sphincterotomy to allow stone retrieval as well as spontaneous passage of retained stones. Now we go to bile duct infections. We have cholangitis. Cholangitis is one of the main complications of choledochal stones. Acute cholangitis is an ascending bacterial infection associated with partial or complete obstruction of the bile salts. Hepatic bile is sterile, and bile in the bile ducts is kept sterile by continuous antegrade bile flow and by the presence of antibacterial substances in bile, such as the immunoglobulin. Mechanical hindrance to bile flow facilitates ascending bacterial contamination from the bowel. The positive bile cultures are common in the presence of bile duct stones as well as with other causes of obstruction. And the most common organisms cultured from bile in patients with cholangitis include E. coli, Klebsiella pneumoniae, Streptococcus faecalis, Enterobacter, and Bacteroides fragilis. And gallstones are the most common cause of obstruction in cholangitis. Cholangitis may present as anything from a mild, self-limited episode to a fulminant, potentially life-threatening septicemia. Patients with gallstone-induced cholangitis are most commonly older and female. The most common presentation is fever, epigastric or right upper quadrant pain, and jaundice. These classic symptoms is known as Charcot's triad. They are present in about two-thirds of patients. The illness can progress rapidly with the development of shock and altered mental status, known as Reynolds Pintad. And then abdominal examination is indistinguishable with patients with acute cholecystitis. Leukocytosis, hyperbilirubinemia, and elevation of alkaline phosphatase and transaminases are common and when present support a clinical diagnosis of cholangitis. Ultrasonography is helpful as it will document the presence of gallbladder stones, demonstrate dilated ducts, and possibly pinpoint a site of obstruction. CT scanning and MRI can show pancreatic and periampullary masses, if present, in addition to the ductal dilatation. However, abdominal imaging will rarely elucidate the exact cause of cholangitis, and the initial diagnosis is generally made clinically. The definitive diagnostic test is ERCP. The initial treatment of patients with cholangitis includes broad-spectrum and IV antibiotics to cover enteric organisms and anaerobes, fluid resuscitation, and rapid biliary decompression. This is most often accomplished through ERCP and sphincterotomy. ERCP will show the level and the reason for the obstruction, allow for culture of bile, permit the removal of stones if present, and accomplish the drainage of the bile ducts. Definitive operative therapy should be deferred until the cholangitis has been treated, and patients with cholangitis has a mortality of approximately 5%. Now we go to primary sclerosing cholangitis. PSC is an uncommon disease characterized by inflammatory strictures involving the intrahepatic and extrahepatic biliary tree. It is a progressive disease that eventually results in secondary biliary cirrhosis. It has no clear attributing cause, and most patients are symptomatic when diagnosed and may complain of intermittent jaundice, fatigue, weight loss, pruritus, or abdominal pain. Of the patients with sclerosing cholangitis, 10 to 15% will develop cholangiocarcinoma, and cholangiocarcinoma in the setting of PSC frequently follows an aggressive course. Diagnosis of PSC is done by ERCP, which reveals in multiple dilatations and strictures of the intra and extrahepatic biliary tree, which confirms the diagnosis. The hepatic duct bifurcation is often the most severely affected segment. Another way is by liver biopsy. This is to determine the degree of hepatic fibrosis and the presence of cirrhosis. There is no known curative treatment for primary sclerosing cholangitis, and medical management is largely supportive. For patients with extrahepatic and bifurcation strictures but without cirrhosis or significant hepatic fibrosis, surgical management with resection of the extrahepatic biliary tree and hepaticojejunostomy has produced reasonable results. And for patients with primary sclerosing cholangitis and advanced liver disease, liver transplantation is the only option. Now we move on to bile duct tumors. Cholangiocarcinoma is a rare tumor arising from the biliary epithelium and may occur anywhere along the biliary tree. Risk factors include primary sclerosing cholangitis, choledochal cyst, ulcerative colitis, hepatolithiasis, biliary enteric anastomosis, biliary tract infections with chlororchis, liver flukes infection, dietary nitrosamines, thorathrust, and dioxin. 95% of bile duct cancers are ductal adenocarcinomas. About half of all cholangiocarcinomas are located in the perihilar region. 40% occurs in the distal common bile duct. Perihilar cholangiocarcinomas are also referred to as Klatskin tumors. This picture shows the Bismuth-Corlett classification of Klatskin tumor. So we have types 1 to 4. Type 1s are tumor below the confluence of the left and right hepatic ducts. Type 2, tumors reaching the confluence. Type 3A, tumor occluding the common hepatic and the right hepatic ducts. Type 3B are tumors occluding the common hepatic and the left hepatic ducts. Type 4, tumors that involves the confluence in both the right or left hepatic duct. And type 4B are tumors which are multicentric. Clinical manifestations of cholangiocarcinoma includes painless jaundice, pruritus, mild right upper quadrant pain, anorexia, fatigue, weight loss, and sometimes would present with cholangitis. Diagnosis of cholangiocarcinoma can be done by use of tumor markers. CA199 is the tumor marker for cholangiocarcinoma. It has 79% sensitivity and 98% specificity if the serum value is more than 129 units per ml. Another way is by ultrasound or CT scan, which will reveal a dilatation of the intrahepatic biliary tree. Another way of diagnosis is by ERCP, which will reveal a detailed evaluation of the biliary anatomy and also the tumor. And then we have also PTC. This is done if the proximal extent of the tumor remains in question, and also to determine resectability of the tumor. Tissue diagnosis can also be done through fine needle aspiration by percutaneous or endoscopic approach and also biliary brushings. However, it has a low sensitivity in detecting malignancy, about 15 to 60%. We also have choledocoscopy. They may be able to improve diagnosis rates, but is only available in specialized centers. For the treatment, surgical excision is the only potentially curative treatment. Resectable diseases should first undergo diagnostic laparoscopy. And for curative resection, the location and local extension of the tumor dictates the extent of the surgery required. Like for example, for distal bile duct tumors, pancreaticoduodenectomy or Whipple procedure uh, is done. And for unresectable on surgical exploration, the surgeon may do Roux-en-Y hepaticojejunostomy, cholecystectomy, and gastrojejunostomy. For Bismuth-Corlett type 1 or type 2, with no signs of vascular involvement, local tumor excision with portal lymphadenectomy, cholecystectomy, common bile duct excision, and bilateral Roux-en-Y hepaticojejunostomy is a surgical procedure. For Bismuth-Corlett type 3A or 3B, could be right or left hepatic lobectomy. And for type 4 Klatskin tumors with more extensive involvement of both the hepatic and the extrahepatic duct, these are often considered unresectable and liver transplantation is the only option. Non-operative biliary decompression can also be performed for patients with unresectable disease on initial presentation. Adjuvant chemotherapy has no proven role. Adjuvant radiation therapy has not been shown to increase either quality of life or survival in resected patients. And for unresectable diseases, palliative chemotherapy is done. That would be all for this topic. Thank you for listening and stay safe always.